Hey everyone, my name is Danuga Tolan. I'm one of the senior research analysts covering biotech here at Chardan. It is my pleasure to introduce Anirvan Ghosh, the CEO of Unity, to our second annual virtual ophthalmology summit, where the focus of today's discussion is on AMD and diabetes-related ocular diseases. Anirvan, it's a pleasure to have you.
Thank you, Daniel. Thank you for having me.
Of course. So to get things started, can you please take a few minutes and introduce yourself to the audience, as well as talk about your company and some of the key milestones?
Of course, I'm CEO of Unity, and I've been in this role for about the last 4 years. I come from an R&D background. I was head of research and early development at Biogen and led neuroscience research at Roche before then. For the past 4 years, it's been a great pleasure to lead the Unity team as we try to develop a new class of therapeutics for retinal diseases. The approach, as you'll hear, is around developing senolytics, a new therapeutic approach that we think can bring differentiated treatment options for patients across a range of indications.
Got it. Excellent. Yes. So before we jump in, the understanding is, we have a number of approved medications that seem to be doing the function pretty well. From your perspective, why do you think the new treatment or a new approach is needed in those indications?
Yes, it's very useful to have that perspective. As you know, the standard of care for about 10 to 15 years now has been anti-VEGF treatment for retinal diseases, DME and AMD. Our focus here is on diabetic macular edema. And anti-VEGFs do help a lot of patients, and hence is widely used. As you know, that these are very big products that have been the lead products now for over a decade. However, despite continued treatment with anti-VEGFs, many patients do not get optimum vision. Most of the patients will not get to 20/20 vision. And historic studies in DME patients suggest that about half the patients will not get to driving vision, which is 20/40 vision. So although they have significantly improved compared to where they were, they still suffer from lack of independence and visual loss. So there's a significant unmet need in the field. And we believe that other variants in anti-VEGFs is not really going to solve the problem. So the field has continued to develop various kinds of anti-VEGFs. You'll hear a lot about those. But there is another biology that we believe is critical in the progression of disease, and targeting that can allow us to break that efficacy barrier that we reach with anti-VEGFs. So we see an opportunity for new therapeutic options that are based on an independent mechanism of action.
Okay, understand. So the approach that you're alluding to is targeting senescent cells in retinal diseases. To kind of orient the audience about this approach, can you explain what these cells are, how they're formed, or what is their association or role in different ocular diseases, and why do you think removing them is important?
Absolutely. I think it's good to just talk a little bit about the pathophysiology of a disease here, and then we can put the senescent cells in context. So in diabetic macular edema, what happens is that you have a significant amount of fluid leakage from the blood vessels in the eye, and you have an inflammatory state as a result of which there are elevated levels of factors such as IL-1 beta, IL-6, TNF alpha, and so on, all of which are believed to lead to disease progression and lead to loss of visual acuity. An observation that our team made several years ago, and which is the foundation of the program, is that as the disease progresses, there's a group of cells in the vasculature of the eye that end up in a non-dividing metabolically active state called senescence. And senescent cells have this feature, which is that they are dysfunctional and they secrete a lot of inflammatory factors and do not form nice tight junctions with their neighboring cells. The consequence is that you have leaky blood vessels and you see the pathophysiology of disease. I should also mention one of the factors secreted by senescent cells is VEGF, which is the target of the leading therapy in the field. So the senolytic approach hypothesizes that if you're able to target and eliminate the senescent cells, then the nearby healthy cells will create strong tight junctions with the neighboring cells, reduce vascular leak, reduce inflammation, and lead to improved perfusion, improved vision. All of that is strongly backed now both by our preclinical data as well as our early clinical experience.
Got it. And to clarify on the mechanism, so once those senescent cells are removed, do you need any additional agents to restore the normal function, or the leftover healthy cells are able to restore that?
Yeah, no, that's the beauty of it, right? So you're essentially removing the damaging cells from that microenvironment so that the healthier cells are the cells that are left behind that can form healthy tissue. And then you do not need the same kind of continuous treatment that you need, for example, with an anti-VEGF to have long-lasting benefits. So the therapeutic hypothesis is that both that this should lead to restoration of vascular health and vision, and also that it should be a long-lasting therapy.
Okay, makes sense. Okay, so let's talk about your candidate. Your lead candidate is UBX 1325. As you mentioned, it's in development for DME, potentially could be expanded to other ocular diseases, retinal diseases as well. So can you talk about the mechanism of action, like what specifically allows this drug to target senescent cells, as well as how it is administered and how often it needs to be administered, and maybe a quick overview again of the potential benefits over other approaches.
Sure. So the lead product is UBX 1325. It is a BCL-XL specific inhibitor, a BCL-XL being a protein that is required for senescent cells to live, but is not a required survival factor for healthy cells. So the elegance of this approach is that if you inhibit BCL-XL, then you end up getting selective elimination of senescent cells, and the healthy cells are not affected. So that's how the BCL-XL part is connected to the senolytic action. Based on the experience that we've carried out so far and the early clinical data we have, our target profile is an agent that we should be able to administer every 6 months or so. So that's kind of where we're trending. The clinical data, which I'm sure I'll review with you, is also consistent with that profile. So just to put that in some contrast with anti-VEGF agents, the standard of care of aflibercept is kind of prescribed currently every 8 weeks. That's the standard of care treatment. So going from that kind of durability to every 6-month injection, I think would be of significant value to patients.
Got it. Okay. Yeah. So I'd like to jump in and talk about those clinical data that you just alluded to. So last year you presented data from the phase 2 study, Behold DME study. Can you talk about the design and key takeaways from it? Maybe you can mention the patient baseline characteristics as well.
Sure. Yeah. So as I said at the top of the hour, we're keen to develop a therapeutic option for patients who have not gotten optimum benefit with anti-VEGFs. So the study is entirely designed to identify those patients and see whether we can provide benefit to those patients. So in order to enroll in the study, patients had to be on an anti-VEGF for at least 6 months before they got randomized to UBX. And at that point, based on prior studies with anti-VEGFs, we know that they would have reached their anti-VEGF plateau. Now, for our study, at that plateau level, they still had to have significant visual acuity deficit. So they had to have 73 letters of vision or worse. The actual enrolling population had a baseline of about 60 ETDRS levels, so really poor vision. And they needed to have fluid of greater than 300 microns. In actuality, the incoming patient population had about 425 microns of fluid. So this just also highlights the unmet need, right? These patients have been on anti-VEGF for 6 months. In our study, they were getting an anti-VEGF every 6 weeks. And still, they had about 60 letters of vision, 420 microns of fluid. At that point, they get randomized to either a sham arm or to the UBX arm, and then we follow them out initially to 24 weeks, which is our primary endpoint, and then we extended the study to 48 weeks.
Okay. And in terms of the anti-VEGF rescue criteria, can you mention what those were and were they consistent among physicians? Because this seems like this is one of the areas in clinical trials that physicians have some say or preference in terms of how they treat and rescue patients.
Yeah, so we use criteria that are the most widely used criteria for rescue in the field. which was a 10-letter drop in vision, ETDRS scores, from their peak vision, or a 75 micron gain in fluid from their baseline. So those are the criteria that the physicians used. As in other studies, the physicians always have discretion to use an anti-VEGF rescue if they feel for some reason the patients need rescue. I think maybe this is a good point to comment on the rescue, because one of the most striking elements of the data set was the level of reduction in anti-VEGF treatment that we needed in patients who had been treated with UBX. So I told you the patients were coming in getting an anti-VEGF every 6 weeks. In our study, through 48 weeks, over half the patients did not need an anti-VEGF rescue. So they really became anti-VEGF independent. And the ones who did need anti-VEGFs, they maybe needed 1 or 2 anti-VEGFs through the course. So there was a very significant drop in need for anti-VEGF, even among the ones who were rescued.
Okay. And so in that study, I believe more than 50%, right, of patients did not require any rescue over the course
That's right.
of 6 months or longer. So mechanistically, can you explain how UBX 1325 is able to achieve that prolonged effect?
Yes. So as I mentioned, the way the senolytic drugs are supposed to work is by eliminating the cells that cause damage to the tissue. And once you eliminate them, the drive for fluid accumulation and drive for loss in vision should go away. So you should be able to get long-lasting maintenance of that effect, which is essentially what we see. An element, because it is a biological remodeling of the retinal tissue, it takes about 6 to 8 weeks for the UBX effect to kick in. That's what we see in the data. There's a very early transient effect that's seen on both arms. But beginning at about 8 weeks, the curves start to separate significantly. As you know from the BCVA data, beginning at that point, we start to see an improvement in vision in the UBX-treated arm versus the sham arm. Now, that improvement in vision is maintained for a very long period of time, which would be consistent with the idea that you removed the kind of the disease-causing element, because the drug is eliminated from the eyes within days, and which is also an important feature. Unlike an anti-VEGF, which stays in the eye for the entire duration of treatment, here we have a transient treatment that leads to long-lasting benefit. In our case, I talked about the fact that we anticipate that maybe we would have an every 6-month kind of treatment effect, because all of this is still happening in the context of a systemic disease. These are diabetic patients. These patients have had diabetes for 20 years, that have DME for 3 years. So although we're treating the eye and removing the eye pathophysiology, the overall diabetic drive is there. So I think we have to be kind of pretty careful about kind of clamping down on further disease progression, which we think we can achieve by a 6-monthly dose.
Got it. Okay. And over the course of this study, can you comment on BCVA values and fluctuations, as well as the effect on stabilizing CST?
Absolutely. So just to recap what the primary data sets were with regard to BCVA and CST. So BCVA is a primary outcome, which is also the registration outcome. So being able to see a signal in BCVA is very important. In our case, what we saw in patients who had been already plateaued on their anti-VEGF, after treatment, we got about a 6.5-letter improvement in vision by week 24 that was then maintained all the way through week 48. So that's a very significant improvement compared to the fact that from historic data, if they had remained on anti-VEGF, they would stay within about a letter of where they were, right? So pretty significant vision improvement in this pretty tough patient population. So that, I think, is what got us most excited. With regard to CST, these patients come with a lot of fluid, right? And as we mentioned, that they had a lot of fluid despite having anti-VEGF treatment. So essentially the maximum effect you can get with an anti-VEGF is where they're starting out with regard to fluid. What we noticed is that once we removed anti-VEGF and then randomized patients on the sham arm, they started accumulating more fluid. So within about 8 to 16 weeks, you see a significant accumulation of fluid in the sham arm. But in the UBX arm, we see no additional accumulation of fluid. And we see actually a gradual reduction as you go from about week 8 all the way out to week 48. So this fact that it can prevent further accumulation of fluid and stabilize the retina is a really important element of its effect, because most patients in the clinic get treated because they accumulate fluid. So these patients are high use patients. They come in, the physicians see that the fluid is increasing, they give them an anti-VEGF. But if the fluid is not increasing, they don't need to give them an anti-VEGF, which I think also accounts for a significant drop in the need for anti-VEGF rescue.
Got it. Okay. And I guess one last question on the Behold study. Can you summarize the safety findings?
Yeah, so this is also something that we were very pleased about. The safety finding now across multiple studies has been very positive. In ocular disease, there's a lot of sensitivity to any sign of inflammation. So very rare inflammatory events can really kind of derail treatment because it's hard to manage. So far, we have had no instance of intraocular inflammation or endophthalmitis or any serious retinal adverse events. The adverse events that were reported are balanced across the arms and are not related to treatment. So we feel very good about the treatment, the safety profile, which I think also allows us to continue to develop the drug for broader use.
Got it. Okay. So I'd like to switch gears and talk about your ongoing phase 2b study, the Aspire study. First of all, having completed the Behold and seeing the results there, what were the key takeaways from Behold that you incorporated or changed as you were designing Aspire?
Yeah, so I'll start with the fact that I think that we enrolled exactly the right kind of patients in Behold, right? So we had gone after patients who have this big unmet need. And it's actually useful to remember, because when you look at some of the other treatments that are in clinical development for other like long-lasting anti-VEGFs, it's the opposite kind of patients that they select. They select the best responders, and then they see, can they give them some additional duration. So there is no treatment that is specifically targeting the unmet need that we're aware of. So we took these patients, and I think we saw a nice response in these patients, which is where we feel that this product could be positioned. And so that's being directly implemented in Aspire and is in our thinking with regard to a pivotal study. So the criteria are very similar. The slight adjustments we have made are to further optimize the patient population. So we had seen that frankly the worst patients did the best in terms of their response. So although our original inclusion criteria was 73 letters, in this we tightened it further to 70 letters or worse, so that we are really focusing on those patients that had the best response and who have the most need. Same thing on the fluid. The criteria for the first study was 325 microns, and then here it's going to be 300. Sorry, it was 300 microns. This time it's 325 microns. So they were really targeting those patients who have the most need. So patient population is very similar. We're really not shifting it in the Aspire study. The Aspire study is a head-to-head study against Eylea or aflibercept, which is important to mention, right? And we believe that this is important because it will give us a very good view of how it could be positioned against aflibercept, which is standard of care. It also helps physicians know, like, okay, are these the kinds of aflibercept patients that would be the right patients to switch into a treatment like UBX? And with regard to the endpoints are likewise similar. BCVA at 24 weeks is the primary endpoint. We'll also evaluate CST to see whether we have the same effect on managing fluid. So not very many changes, frankly, between the first study and Aspire. The minor change that I should highlight is that in the Aspire study, the standard of care of aflibercept is given every 8 weeks, per label. And we wanted to have a design where we give matched treatments on the UBX arm, which has two effects. One is that it's, in our view, of truly head-to-head comparison. So you're given the same number of treatments in both arms, and it will maximize the UBX benefit. Like, what is remarkable in the first study is that we saw all these gains after a single UBX injection. We didn't give anything beyond that. Now, it still might be the case that for long-term treatment, just coming in every 6 months is going to be enough. But we want to make sure that the patients get to that UBX maximum response before we extend them. So by giving them 3 injections of UBX, we feel we'll also know what the maximum UBX response is to optimize the efficacy on the UBX arm.
Okay, got it. So that's the key difference in dosing regimen versus Behold? And in terms of the dose itself, is that the same dose that you used in Behold?
Yeah, exactly the same dose, a 10 microgram dose, which has been working well.
Okay, got it. And in terms of the size of the study, what is the size? What is it powered at, and how does that differ from Behold?
Yeah, so the study is designed to be a 50-patient study, equally randomized between UBX and aflibercept. One additional element that I'll mention, which actually goes into further refining the patient population, is that the patients get 3 loading doses of aflibercept before they're randomized, so that we are absolutely certain that they have reached the aflibercept peak.
Mhm.
Uh, the study is powered as a non-inferiority study with the same margin that is the standard approval margin, which is a negative 4.5 letters of the negative confidence interval of the compared to the Eylea arm. So it's powered to be a non-inferiority study, and we believe that we'll have enough patients to get a very clear answer on that. Of course, as in any other study, we're going to look to achieve the non-inferiority margin, but also look for signs of differentiation. The areas of differentiation, based on our prior studies, to pay attention to would be what the BCVA arm looks like compared to the BCVA and the aflibercept arm. On the aflibercept arm, we expect it to be flat, right, close to zero change based on prior treatment. And we'll be looking to see if we can give additional letters on the UBX arm compared to that. And of course, we're going to be looking for a reduction in anti-VEGF burden in those patients.
Okay, got it, understand. And in terms of the duration, just to clarify, so Aspire, I understand originally was designed as a 24-week study, right? Is that still a primary endpoint, or are you extending that to 36 weeks?
Yeah, so the primary endpoint is still at 24 weeks. And we had selected that because in the prior study, we saw that by 24 weeks, we saw a full response to UBX. So we had a very good sense of what the efficacy would look like at 24 weeks. And 24 was very predictive of what would happen going forward beyond that, all the way to 48, right? So beyond 24 and 48, there's like relatively little change. So the primary endpoint of the study is 24. Now, with regard to value to patients and physicians, there's always this question about reduction in treatment burden, right? And so in the 24-week study, because there's treatments that are happening every 8 weeks,
Mhm.
it's the first 24 weeks is really optimized to see the efficacy difference, if any, between UBX and Eylea and aflibercept. But we thought that if there's an opportunity to generate some durability data, that would be nice because we have ongoing studies. So we decided to extend it to 36 weeks. And that'll allow us to see that between the last injection, which happens at week 16, all the way to 36 weeks, there'll be a 20-week period when there are no planned interventions. So that'll allow us to see that can we see a reduction in anti-VEGF use in that 20-week period, which again, based on our prior study, was pretty predictive of what would happen at 48 weeks. You might recall in Behold, most of the rescues happened early, pretty much all within the first 18 weeks. So beyond 2024, we would typically expect very few rescues. So we'll have a good sense of that rescue need by 36. So that's the total duration of the study. We also, at this point, we're not planning a forever study because we'll keep generating durability data because we are quite mindful of trying to get this into a pivotal study, which we hope we can get to late next year. And, every few months that we add to a phase 2 study shifts the timeline of a phase 3 study.
Okay, yeah, makes sense. So to get to the pivotal by the end of next year, can you summarize the key upcoming milestones for the Aspire study over the next I guess year or so?
Yeah. So, we're totally focused on execution right now, and we are on track to share 24-week data, which is a primary endpoint data in Q1 of 2025, and then to share 36-week data in the second quarter. So those are kind of the most significant milestones coming up with regard to data for UBX 1325. We've already started planning a potential pivotal study based on what we learned from Behold, the kinds of patients we would need, thinking about endpoints, study size, et cetera. And our intention is to be able to start a pivotal study towards the end of next year.
Okay, understand. Okay, I know you only have a few more minutes left. With respect to pipeline, any other updates that I didn't ask you about that you feel investors should know about?
Yeah, I think that the focus on 1325, I think is the right place to have this conversation. I think what's important for the broader investment community to understand is that despite the fact that anti-VEGFs are huge products and have been very successful for a long time, a very
Mhm.
sizable fraction does not get to optimum vision. And so that unmet need is real and a real opportunity. And I would say that in the broader field, even among physicians, because there has not been an agent like that has broken that anti-VEGF barrier, there is some mix of perception between that, well, they all respond well to anti-VEGFs, or it is impossible to break that barrier. I would say that
Mhm.
I believe, and I think our data shows that it is possible to get to that unmet need by targeting a different mechanism of action. So I think that if we end up in a data set that's anywhere close to behold in the Aspire study, that is a game changer. Like if you see letter superiority compared to Eylea or duration superiority, those things have not happened. So that I think is the most important thing to keep in mind with regard to the potential for UBX 1325. I'll just comment briefly that, further down in the pipeline, we have two biologic agents that are at a GLP tox stage that I think they have very interesting differentiated profiles compared to faricimab, which is the product that targets Ang2 and VEGF. But right now, we
Mhm.
have not been investing in that program because we're really focused on advancing UBX. But of course, as the program moves forward, that is an asset that could also create significant value.
Got it. Yeah, hopefully next year when we have our third annual summit, we'll be in the position to talk about those programs. I guess one last question. In terms of the company's operational runway and what assumptions are you making for that?
Yeah, so based on our latest filings, our current runway goes into Q3 of 2025. And that's important because that gets us through both the 24 and 36-week data readouts, right? So our near-term horizon is to get to these data readouts. We have funding to get beyond that. And of course, as we move towards 24-week data readout, we'll be paying a lot of attention to uh, the way we fund the company and how we finance the next study.
Got it. Excellent. That's all I have on your one. It was great to have you participate in the summit and look forward to having you again. Thank you very much.
Thank you very much for having me.